to the introduction, and I'm going to do again, as sir said. I hope you can see my screen.
Yes, we can.
Okay, go to full screen. So so this is a journal club. Usually in journal clubs, you take one article and you focus on that. However, I thought I'll try and focus on a concept of causation, association, and how do you prove causation. And I'll use three of, in my mind, papers that are across the spectrum of time. So one that just came out in 2022, which is the AntiNephrin for minimal change disease. So that's at the start of the journey. SflT1 for preeclampsia, the paper that came out in 2003. So there's been a lot of work that has since happened. So we know what the original paper is, and then kind of how things have panned out for it so far. And then PLAR2, which came out in 2011. And again, there's been a lot of research and work that has happened. So it's good to kind of go back to the original paper and see what did they show in the original paper, and to see how much of proving causation or proving causality they had shown in the original paper, and what all things were left afterwards, which have been done in subsequent studies. Okay, so the outline is going to be in terms of proving causation. I think two things that we should keep in mind are Cox postulates and Bradford Hill. So I'll go a little bit about it. Another two concepts are a cause or a factor can be necessary to cause a disease. It may be sufficient to cause a disease, and it may be necessary and sufficient to cause a disease. So these are important concepts when we are trying to prove causality and what kind of role the cause or a factor has in causing a disease. It's important to keep these in mind. And then we'll go into the three papers and focus predominantly on what they found and what their discussion was in terms of how they linked it to causality. So, and then how do we assess those papers? So some of the common fallacies that we can get into when we think about something is that something happened after, therefore it was because of this. So just because I was humming a tune about the clouds and then it rained doesn't mean that I was the cause for that rain. And so there can be similarly associations or correlations that we can find in scientific studies or case and controls or diet research, where there's a lot of this association correlation, but that does not mean causation. And so to prove causation, you need to go through a lot of work and effort. And just because you see two things going on together, where someone's trying to stop a train and the train stops, doesn't mean that they are the cause of the train stopping. Or if they're pushing and the train moves, doesn't mean that they're the cause for things starting. So that I think is something that we have to keep in mind when we're doing causation or assessing it. Let's get into the Cox postulates. So the first one is that you have to, so on the top is a healthy organism, and in that you shouldn't find whatever causative organism that you're trying to identify as the cause of a disease. So in those healthy people or healthy organisms, it should be absent. In those diseased organisms, then that suspected agent should be found. So the suspected agent must be absent from all healthy organisms, but present in all diseased organisms. So that's postulate number one. The problem is that these postulates were originally designed for the microbial concept of disease. So this may not directly apply to causes which we think are not microorganisms, but it is still good to kind of think in this line and kind of use that as a template. Next is asymptomatic carriers. Again, saying that it should be absent from healthy people or healthy organisms or those who are asymptomatic. We know that there are asymptomatic carriers of disease as well. The second postulate is that the causative agent must be isolated from the diseased organism and grown in pure culture. So that again is a microbial centric concept, but again, we can apply it to other situations as well, where you have to isolate it from the organism or from the diseased organ or the location as well. And then it may be a problem in terms of difficult to grow organisms, or if it's not an organism as well. Third is that then the cultured agent should be injected into healthy organisms, and you should replicate the disease when you inject it into the healthy organism. So again, maybe diseases in which it is not a one-hit disease, so you inject the causative agent, but you need additional hits as well. So in those situations, this postulate may not be possible to be replicated. Then the fourth is that from this organism who has been injected with the disease, with the suspected agent, you have to get the causative agent again and re-isolate from the inoculated disease organism. So again, sometimes you can have one organism with multiple diseases. So again, that can be an issue in trying to prove these postulates. So now we'll go to the Bradford-Hill criteria. And so there are multiple criteria. And the first one is temporality. The cause has to precede the effect. So this is something that is absolutely required, but may require multiple investigations to ensure that the cause is preceding the effect. Next is plausibility, meaning that the association that we are finding is consistent with the existing knowledge. So again, our knowledge could be limited, and so as we grow, we might find new associations. So this may not be true all the time, but again, you do want biological plausibility, that it should make sense. It shouldn't be something which is completely inconsistent with what is possible in the world. Consistency, you want multiple studies to show similar results, and that increases the possibility that the cause and effect that you're trying to assess is real if you find it in multiple studies that have been done, all of them showing the same result or the same association. Strength. So this is something where a stronger the association, the more likely, according to Bradford-Hill criteria, the cause and effect. However, we do know that there are occasions where a weak association may be real, but a strong association may be confounded by some unknown confounder as well. So that by itself, just the strength of association by itself doesn't mean that this is a real cause and effect. Dose response. So again, the higher the exposure or the more the dose that someone gets to, the more the effect. So if you find a dose response association, that also increases the likelihood that this is real, but again, doesn't prove it. And so you're trying to line up all these criteria and have multiple of them to ensure that we are not making just a general assumption. Reversibility. If we reverse or remove the cause, the disease or the effect should disappear. So again, if you show reversibility, that again increases the likelihood that this is a real cause and effect. And then study design, is it a robust study design, or does it have multiple flaws or biases, which may be the reason why you're seeing the cause and effect? And so that is something that you do want to assess as well. And then evidences. So you want multiple different ways or methods. So you could have a randomized control trial, case control, observational studies. So you want multiple sources of evidence to prove it. Animal studies, in vivo, ex vivo studies. So you want all these evidences to kind of line up together. And the more the different lines of evidence, the stronger the proof that this is a cause and effect and not just an association. Okay. Now we'll talk a little bit about necessary and sufficient. So what necessary means is that a risk factor or a cause has to be present for the disease. So if you remove it or if it is not there, then the disease cannot develop. So whether it is a sickle cell mutation or a BCR-ABL for CML, that is necessary for the disease. If you don't have it, you can't have the disease. sufficient means a risk factor is enough to cause the disease. However, other factors may be also causing it, or additional factors or additional hits may be needed. For example, hyperaldo is sufficient to cause hypertension, but it's not necessary because hypertension is a multifactorial disease. So you can have multiple pathways to it. So it's not just a one path to hypertension. Some factors are necessary and sufficient, and some are only necessary and some are only sufficient. So again, this is something that as you assess the cause and effect relationship, you should also think about, is this cause and effect only necessary, sufficient, or necessary and sufficient? Now let's look at the paper that came out in JASN that talks about antinephrin for minimal change disease. This is the classic figure 1 that you will see across all studies that are trying to prove a cause and effect. And this is trying to prove Koch's postulate 1, which is that it is found in the diseased animals or diseased conditions, but not in healthy or not in other diseases which are similar. So in this, they took patients from the Neptune cohort as well as healthy volunteers. So the top A is the AntiNephrin antibody, which was done by an ELISA. And in healthy, they checked what the AntiNephrin levels were, they made their threshold, and then they compared it to patients 62 from the Neptune cohort who had minimal change disease, and they found that around 30% of them had high nephrin antibodies. And then they looked at people with PLAR2 positive membranous, and they looked for antinephrin antibodies there, and the nephrin antibodies were negative. So panel B is same patients with minimal change disease from the Neptune cohort who were positive, and then they had repeat samples done for some of them, and this was during remission. And what they show is that the blue is where they are in remission, and the antibody level is gone or has disappeared for this same patients who were antibody positive. So during active disease, there is antibody, and when they're in remission, the antibody disappears. And then
in both in panels A and B, the dotted line represents the threshold of positivity, right?
Yes, yes, the dotted line is the threshold, and this threshold was derived from the healthy volunteers. And so this 30 healthy volunteers is from where they drew their line for threshold for positivity. And then in column C is where they have taken human glomerular extract. So they ground up normal glomeruli, and then they expose them to the serum from patients. So A is in active disease, R is in remission, and then the antibody would bind to the nephrin if nephrin is the only antigen that these antibodies or these serum are binding to. And then they went in with an anti-human antibody derived from sheep to kind of lock in this. And so now the nephrin is present in those who are active, and it's absent in the remission. And so you can see all these patients who were positive, there's some slight antibody in some, but stronger antibody in others. And then they have the IgG heavy chain as a control for their blots. So conclusion is that it is present in minimal change disease in some, but not all, so 30%, but it is not present in normal or healthy volunteers, and it is not present in those with membranous. So just because of nephrotic syndrome, proteinuria, hypoalbuminemia, those syndromes by itself doesn't drive this antibody. So it's not a coexistent entity, but it's a separate entity. So that's what they're trying to prove here. The other part is it's present during active disease, absent in remission. So again, trying to prove some of Koch's postulate as well as the Bradford Hill criteria. And then serum precipitates nephrin from the glomerular extract. Again, that this is specific to the glomeruli, and there aren't other antibodies in the same patients as well. So where did this story start from? So this is an immunofluorescence, and the story starts with Dr. Renke, who's a pathologist, who noted these small speckles of punctate IgG in minimal change disease. So for 20, 30 years, he's been writing in his reports that there are these punctate IgG that are present in patients with minimal change disease. And these are not protein resorption droplets because albumin stain doesn't show these punctate staining. So this is albumin. And so this is real IgG. So he's been writing about this, but most of the other pathologists note that immunofluorescence is negative because it's not the linear or the granular staining that we associate with membranous or other immune complex diseases. So this was more fine and more punctate. And on light microscopy in the same patient, you see minimal change disease, which is classic, nothing on light, and no deposits on EM, which is why the immunofluorescence wasn't commented upon by other pathologists, because they couldn't see any evidence for it on EM. So what they then did is they took these patients with kidney biopsies of minimal change disease, and they did staining. So green staining for IgG and red staining for nephrin. And what they're trying to prove is that the IgG deposit that is there is actually against nephrin. So on the left panel are glomeruli that they have stained. And what you want to look for are these yellow. So green and red, if they're exactly together on top of each other and at the same position, the color will be yellow in these confocal microscopes. And so what they're showing is on the first panel on the left is these yellow lines in the glomeruli, and the arrowheads are where the IgG and nephrin are co-localizing. And so that's what they're talking about. On the right is synaptopodin, which is a podocyte protein. And what they're showing is that it is not that it is just IgG co-localizing with any random podocyte protein. It is specific to nephrin. And so that's what they're trying to prove by showing that if you do it for synaptopodin, which is another podocyte protein, that the green and the red are close together, but they're not turning yellow because they're not co-localizing together. So these are the two minimal change disease patients on the top two, the top four on the left and the top four on the right. And so they're showing you that they are yellow punctate deposits which are co-localizing IgG and nephrin. The bottom are minimal change disease, but there was no IgG deposit when you do it with immunofluorescence. And so what they're showing is that in this, the IgG nephrin is not showing any co-localization. And again, similarly, IgG and synaptopodin are not showing any co-localization. So whatever they're finding is real IgG deposits, which are actually against nephrin. So that's what they're trying to prove. And then they look at it on a different, so this is different look, which is with a SIM to show you these nice fine lines of yellow, which are again with IgG and nephrin in a minimal change disease patient. While if you do it with synaptopodin, there is no yellow. The IgG deposits are separate from the synaptopodin. So this is another look in this for the same, proving the same concept. Then they looked at the antibody, those with antibody from the Neptune cohort and those who were antibody negative to see what their response was. So what their complete remission was. And there wasn't any difference between the complete remission of the antibody positive or antibody negative. The treatments were different, and what treatment is there is in the supplements, and I'll not go into that. The relapse was slightly higher, so it didn't reach statistical significance, but at least visually it looks like those with antibody positive may be relapsing earlier in the red compared to those who are antibody negative. But again, this is small numbers, so we'll have to look for more data from different cohorts before we take this at full value. Then what they did is they did a second cohort of minimal change other than the Neptune cohort, and they had 9 biopsies in which there were IgG positive punctate deposits, and all of them had anti-nephrin antibodies that were high. And then they had normal controls like lupus and diabetic nephropathy, FSGS, and other controls, and they did not have any anti-nephrin antibodies. And again, for those that they had serial antibodies, again, the dotted line is the threshold, and then in remission, the antibodies had disappeared, and for some they had multiple readings. So you can see the multiple circles for the patient with multiple readings. So while they had active disease, the antibodies were there, and when the disease was in remission, the antibodies were absent. So again, trying to prove that when the disease is there, antibodies are there. So trying to prove causation, and when the antibodies are gone, the disease is gone. And then lastly, they present this unique case. So this is someone who had early childhood nephrotic syndrome, then progressed to FSGS and end-stage renal disease by her 20s, and then received a kidney transplant. So the blue is the serum creatinine, and 0 is the day of transplant. So creatinine came down nicely, very quickly down. And then by day 10, there was proteinuria, which is the red line that started. And this was thought to be recurrence of minimal change disease or FSGS on the same spectrum, treated by plasmapheresis. So the gray lines are plasmapheresis. The orange is rituximab. So the patient received 5 plasmapheresis, 2 rituximab, and the proteinuria went away by day 30. So what they did is, for this patient, they did have multiple serum that were many days before the transplant, so 617 and 528 days. And the antibodies, anti-nephrin antibodies, were present. They didn't have the serum at the time of the relapse, but what they did do is they had the effluent from the plasmapheresis. So they checked the effluent of the plasmapheresis, and that also had anti-nephrin antibodies. And then later on, they had serum samples on day 27 and 1 year, and the anti-nephrin was absent, correlating with absence of the disease. So again, they took the serum and they did human glomerular extract tagging, and then looking for the nephrin antibody that way as well, which they found, and which was also in the plasmapheresis effluent. So that's kind of the paper that we have. In terms of plausibility and consistency, they talk in the discussion why they think this is real and not just an association. So nephrin mutations are known to be associated with congenital nephrotic syndrome. So an antibody that binds to nephrin could plausibly change how nephrin interacts at the junctions and lead to nephrotic syndrome. Similarly, it's been known that post-transplant, there's this Finnish congenital nephrotic syndrome, which are also with nephrin mutated, and they've been shown to develop nephrotic syndrome due to anti-nephrin antibodies, which are present after the transplant. So because the nephrin is mutated, the new kidney that they get post-transplant expresses nephrin that the person hasn't seen before, and so they can get these anti-nephrin antibodies, which cause nephrotic syndrome, and they respond to plasmapheresis and rituximab. So this is again trying to show that there are other patients in which this mechanism has already been shown and proven. And then they talk about their patient who had this post-transplant recurrence as well. In terms of mechanistic animal studies, someone previously has already done anti-nephrin antibodies in the 1990s, injected into rats, and leads to an MCD-like presentation as well. So again, showing that this could be in the causal pathway and could be cause for minimal change disease in at least some patients. Now let's look back at Koch's postulates and see which of these postulates they've shown. So in terms of healthy, they showed that in healthy patients, this is not present. in minimal change disease, they only show it in 30% of the Neptune cohort. So it's present there, but all the other parts, they themselves haven't shown it in this paper, but they talk about other papers that may show that injecting antinephrin antibodies may cause disease, which is third postulate. Now let's look at that.
Sorry, Ajay,
Sure.
if we can go back to the previous slide.
Sure.
What do you think about the second of the Cox postulates, in which this they did show that the serum from these patients is able to pull down the nephrin from isolated glomeruli, right?
Yeah. So that is part of this. I'll talk about a little bit more when we talk about the membranous. In membranous, they also did isolated micro dissections, and then pulled down, took those micro dissections of these electron dense deposits, and then showed that those were anti-PLA2R IgG. So that level of dissection hasn't been done here, and that might be because these are small punctate IgG deposits. So they've shown some human glomerular extract pull down with these antibodies. So there is part of this, but not like micro dissection kind of isolation.
Sure. So there is some evidence.
Some evidence
Similarly,
for this.
Similarly for the Cox postulate number 3, not in their study, but
not in their study. Yes.
The animal study from
animal studies
the 1990s has shown that
1990s has shown
into,
yes.
Yeah.
Yes.
So,
So which is why the tick marks that I'm showing here are for the study themselves. It doesn't include anything that is outside the study per se.
Yeah, but for the basic hypothesis,
yes,
these antibodies do cause disease.
I
think if we take, then there is some more evidence.
There's more biological plausibility based on those as well. So, so again, so does the cause precede the effect? So there is some evidence for it based on the presence with the disease and absence when the disease is in remission, but they don't have serial bloods where the antibody was absent before the disease developed, then they had it before at the time of disease, and then it disappears. So they don't have the first part of it, but they do have the second and the third part. Is the association consistent with the existing knowledge? As we looked at all the other evidences that they quote and that are already out there, it seems consistent. Have similar results been shown in other studies? So yes, as we talked about, there are certain evidences, but we would need more, especially more clinical evidence for this antibody and its role. What is the strength of association between the cause effect? Needs more data. Does increased exposure lead to increased effect? Are the titers correlating with outcomes or with proteinuria or with remission and relapse rates? That still needs to be looked into. Does removal of the cause decrease the risk of the effect? So they did show with the plasmapheresis and rituximab that if you're targeting antibodies in a minimal change disease, which wasn't thought to be the case to be effective before, but with this proof of antibody removal through these, we are seeing an impact. And so that again gives us a concept that antibodies are a cause for minimal change in at least some of these patients. And is the evidence based on a robust study design? So the study design itself is pretty robust, though we would like multiple more lines of evidence as time goes on to conclusively prove the cause and effect for nephrin in minimal change. Now we'll switch gears and talk about SflT1 for preeclampsia. And so this paper came out in 2003. So again, the first one is trying to prove, first figure of this paper is also trying to prove Cox postulate 1, that it's found in diseased animals and not in healthy. And so the first top A column is mRNA blots from placenta. So N is normal and P is preeclamptic placenta. So after delivery, these placentas were taken and then the mRNA was looked at, and GAP-TH is the control at the bottom. And what it shows is that there is a FLT1 and SflT1 in normal pregnancies, but in preeclampsia, this is multifold higher. And so there are 3 of these, again, normal and preeclampsia, normal and preeclampsia. So in preeclampsia, there is a multifold higher mRNA expression in the placenta. At the bottom B is serum, and they're looking at time 0, which is time of delivery, and then time 48, which is 48 hours after delivery. So again, in normal, there is some SflT1 floating in the serum. And so this is, but this is absent or disappears 48 hours after delivery. Again, in mild preeclampsia, it's higher. In severe preeclampsia, it is even higher. And again, all of these disappear at 48 hours after delivery. In preterms, which would be similar in terms of gestation duration to preeclampsia patients, it's at a level similar to normal pregnancies. Again, it disappears after delivery. So what they're trying to show you is not only that this is yes and no, but that this is graded levels. The higher the disease, the higher the SflT1. And the mRNA data shows that the serum that we are looking at, the source of that protein is actually the placenta. So trying to prove that the placenta is the source of the SflT1. And it also shows the Bradford Hill dose response. Worse disease have higher levels. So they're showing a little bit of that in this as well. So next, they look at their study comparison and their control groups. So they have 11 normal pregnancies, and their gestational age at the time of delivery is 39 weeks. There's mild preeclampsia in 11, and their gestational is 34. And as expected, they have high blood pressure, while the normal pregnancies don't have high blood pressure. They don't have proteinuria, and they have normal hemoglobin, platelets, and creatinine. While those with mild preeclampsia have proteinuria, have higher uric acid levels, and their creatinine is normal. But while severe preeclampsia, they have much higher blood pressures, much higher proteinuria, and a higher uric acid as well. And they deliver at a much earlier gestation, which is 31 weeks. So to match the 31-week gestation, they took 6 preterms, which are 30 weeks. And again, the other clinical parameters, because they don't have preeclampsia, are normal, but the gestation is similar. So next, they are looking at the biological effect and the biological plausibility. And so in the first column, their concept is that SflT1 binds to VEGF and placental growth factor. And so on the left is a technique that they derived to put SflT and VEGF together and to show that they're binding to each other. On the bottom is SflT and placental growth factor. And what they're showing is the higher the amount of SflT that they put. So circles are controls, the black boxes are SflT1 at 0.5, and then the triangles are SflT1 at 5 nanogram per ml. And so they're showing that the free VEGF that is available is much, much lower if you increase SflT1 compared to if you put less quantity, so that there is SflT1 and VEGF are binding to each other. Similarly, SflT1 and placental growth factor are binding to each other. And so then they take the same assay and look for free VEGF in serum. And they're looking at normal pregnancies. There's a lot more VEGF, free VEGF floating. Then in mild preeclampsia, it's lower. Severe preeclampsia, it's even lower. And again, preterms, it's at levels similar to normal pregnancies. Similarly, placental growth factor, which is free, normal is at this level, mild preeclampsia lower, severe preeclampsia lower, and preterm is around the normal range. So what they're trying to show you again is biological effect, meaning that in the sera, there is SflT1 and it is decreasing the free VEGF and the free placental growth factor that is there. And that is what the binding is about. Then next, they show it in the anti-angiogenic effect of SflT1. So this is HUVEC, which are cultured cells of vascular endothelium. and they usually, once they're growing, have these nice fenestrations and interdigitations that you see in column A. And so this, what they did is they put normal pregnancy serum at time 0. So which is the HUVEC cells were incubated with the normal maternal serum at time 0 of delivery, and then time 48 after delivery. And so they have nice interdigitations on the top. The bottom one is where it was incubated with preeclamptic serum. And what you see is that the interdigitations are all gone. So this is anti-angiogenic effect of SflT, which is what they're assuming. And what they're going to do is then 48 hours later, it comes back. They take this serum, they put extra VEGF and placental growth factor, and these interdigitations come back. So this is showing that this VEGF and placental growth factor is the only thing which is absent. And if that was present, these interdigitations would be there. In the top one, they take the time 0 serum, they add only SflT, and the interdigitations go away. So what they're trying to show is that SflT1 by itself is sufficient to cause the anti-angiogenic effect that is present here, and that this anti-angiogenic effect, even in presence of SflT, can be overcome by extra VEGF and placental growth factor. And they do show that this disappears post-delivery. So they're trying to show that this SflT1 is necessary and sufficient for the anti-angiogenic effect. Then what they show is the vasopressor effect, which is through rat renal vessels vasodilation. And so the first top curve is a dose response curve, where they're showing the effect on the rat renal vessels with S is for SflT. So there are different concentrations of SflT, and nothing happens much, just a little bit decrease, not significantly. With VEGF, there is a significant increase in vasodilation, which is completely halted or reversed when VEGF has SflT together, which is the curve in the middle. Again, placental growth factor is the P, and then completely reversed when placental growth factor has SflT. So this is proof of concept that the mechanism is placental growth factor VEGF inhibition by SflT. And then they look at actual concentrations, which are what you would expect in pregnancy. So they take VEGF at 100 picogram per ml, placental growth factor at 500 picogram per ml, and SflT at 10 nanogram per ml. So by themselves, they cause vasodilation. SflT causes a little vasoconstriction. And when you combine VEGF and placental growth factor, there is vasodilation. You do with SflT, there is a significant decrease in that vasodilation. Next, they move on to doing an adenoviral injection. And so this is trying to prove Koch's postulate, where 3, where you inject the disease, the causative agent into the animal. So what they did is they took FC adenovirus with just the FC fragment, injected it into pregnant rats, and the blood pressure remained normal and there was no proteinuria. Next, they took SflT1 and in adenovirus and injected it into pregnant rats. And what they see is hypertension and significant proteinuria. Then what they do is they take SflK1. So this SflK1 is an anti-VEGF, but has no placental growth factor binding. So what they're trying to show you is that it's not any anti-VEGF agent which could do this disease. It has to be SflT1, because SflK, which is an anti-VEGF, but doesn't have placental growth factor, is not sufficient to cause the disease. So SflK1 with FC in pregnancy doesn't cause hypertension, doesn't cause proteinuria. And then they have the non-pregnant controls in which they give adenovirus as well, which again shows that just the FC fragment does nothing. If you give SflT1 to non-pregnant as well, you get hypertension and you get proteinuria. And if you give SflK, again, you get hypertension and proteinuria, because in non-pregnant, there is no placental growth factor. There's only VEGF. So you do get SflK with FLC, SflK, you get hypertension and proteinuria. So again, they're trying to show that in pregnancy, the only thing that can be the causative agent is SflT1. And then in the same experiment, they looked at the kidney biopsies, and they show that what you see in the kidney and in the glomerulus is something that you see in preeclampsia, which is glomerular endotheliosis, where the glomerulus looks full, but it is not cellular or hypercellularity. It is glomerular endotheliosis. And with SflK1, you don't get it, which is the bottom panel, and the normal kidney biopsy of a rat is on the top panel. And then they show it in electron microscopy as well, which is the second panel, and the normal FC EM of a rat is on the top panel. And you see this significant glomerular endotheliosis on electron microscopy as well. And then in the discussion, they talk about all the other evidences that are there to show that SflT1 and anti-VEGF could be the mechanism for preeclampsia. So bevacizumab, which is an anti-VEGF antibody available for chemotherapy, has been shown to cause hypertension and proteinuria. There are other tyrosine kinase inhibitors, which are also used in oncology, which are VEGF inhibitors, and again have been associated with hypertension and proteinuria. VEGF effect is known from other data on glomerulus and hypertension as well. And there are VEGF knockouts and inducible knockouts, which are also present and have similar phenotypes in terms of hypertension and proteinuria. So there are also other evidences, other studies that had happened before, which had shown separately that there were higher SflT1 levels in patients in pregnancies with preeclampsia. And people had shown that serum from preeclampsia had anti-VEGF activity, but they hadn't identified it as SflT1. So now coming back to the Cox postulate for this, so they do show that it's absent in healthy, or it's at low level in healthy pregnancies and healthy placenta, but at a much higher level in those with disease. They isolate SflT1 and then they've injected the adenoviral SflT1 to show that the disease is recapitulated, not just in phenotype, but also on kidney biopsies and pathology. So I think step 1, step 2, and postulate 1, 2, and 3 are all being shown here in this study. Next, coming to the Bradford Hill criteria, again, they don't show temporality in this paper, but since then there have been studies where they've shown temporality as well. Plausibility, again, they've shown the multiple evidences in their discussion, and similar results from other studies are also quoted. They've shown that there is a dose response curve. The higher the preeclampsia, the higher the SflT level. So that is something that they have shown. The study has a robust design, and after that study, you would want other studies and other evidences as well. And that has accumulated over the last 18 years to make sure that SflT1 is the causative agent. Now we'll quickly try and do a quick brief on the part 2 for membranous. And so again, their first slide is what you expect, which is Cox's first postulate proving or trying to prove that concept that it is found in diseased. So again, this is a Western blot. In MN1 are those with membranous, FSGS, diabetic nephropathy, FSGS, and diabetic nephropathy 3. And so what they find is that in a human glomerular extract, you take these serum, you plot it with the extract, and you get a band at 185 kilodaltons, which is the PLAR2. And it's absent in these other disease conditions, which are FSGS, diabetes, nephropathy. And then they did other controls as well. So the right is a panel of 37 patients, out of which 26 had the anti-PLAR antibody. So 70% had the anti-PLAR antibody. And then in secondary membranous, so this is an interesting control that they had, where lupus membranous or other etiologies with relationship to cancer, secondary membranous did not have anti-PLAR antibodies. So this is like an internal control that the mechanism of disease in secondary membranous is different, idiopathic membranous is different, and this PLAR is specific to this disease. Other diseases, which is like diabetes and FSGS, is absent, and then normal healthy volunteers, it's absent as well. So showing again, found in diseased, not in healthy, and not in other diseases or similar diseases. So that's kind of Cox postulate 1. And then again, they take the human glomerular extract and they are looking at the human glomerular extract, or they did recombinant PLAR antigen, and they're checking it with their PLAR antibody to make sure that it is only PLAR which is there and the serum doesn't have other things which are doing it. So they show that this human glomerular extract, what the PLAR antibody is picking up is PLAR. It's at the right location, at the right size. And then this is positive reducing agent, which is the PNGase F. And when you do that, it's at a different size. And that if you do recombinant PLAR as well, you get it at this size, this place with in reducing conditions. And if you don't do reducing conditions, then at this size because of glycosylation. And then in membranous serum as well, you get the same kind of pattern, depending on whether it's reducing conditions or not. And then this is where the immunoprecipitation is that we talked about earlier, where you do microdissection, you precipitate it out, and then look at it with the antibodies. And again, you have the IgG heavy chain as control at the bottom. Membranous, so there is one membranous patient that didn't have the antibody, that is here on the blot. And then you have the normal controls. And then they have a no serum as well to show that the IgG antibodies are absent in that immunoprecipitation because they didn't have any serum in it. So those are their controls. And then what they do is they look at the IgG subtype. So we do know that in membranous IgG4 subtype predominates. And so what they're doing is they're trying to show you that in these membranous patients, when they take the PLAR and they're showing the PLAR, it is an IgG4 subtype, which is there and is the predominant subtype in this nephrin anti-PLA2R antibody subtype as well. And then now they're trying to show you the localization. So this is not patients with membranous. These are human normal glomeruli. And in column A, they have a PLAR staining, and it stains the glomerulus, showing that PLA2R is present in the glomerulus. They do have the tubular staining as well. And to show that this tubular staining is non-specific, what they do is they incubate this PLAR antibody with PLA2R antigen separately, which is free floating. They remove it and then they check in with the PLAR antibody second time to look for this. And so what they're showing is that there is this non-specific staining of the tubular basement membrane that is there, and the glomerulus are absent when you do that. So that's kind of something because of this tubular staining that they had to do. And then in this D, they're trying to show you the localization of PLAR compared to the glomerular basement membrane, and showing you that the PLA2R is actually in the podocyte cell, and the glomerular basement membrane is green for agrin, and this is localizing there. And then they have the structure of the extracellular domain of PLAR2. And then here they're showing you again IgG4 and PLAR2 co-localization, which you've already seen with the nephrin. So the red is PLA2R, the green is IgG4 deposits in the kidney biopsy with membranous. And when you look at it at the confocal with the PLA2R plus IgG4, you see these nice yellow lines confirming that this is due to PLAR IgG at the same location. So there are two of these kidney biopsies that they're showing from different patients. And then they did the same blocking of PLA2R first, and then they went in with IgG4. So now there isn't any co-localization here. Then they're looking at other kidney biopsies with serum from kidney patients with lupus membranous or IgA, and they also have the PLAR2 antigen to make sure that it's not just the human glomerular extract, but also PLAR2, so that this antibody is specific to PLAR. So those with membranous have antibodies against PLAR, as well as they're pulling out from the human glomerular extract a protein which is the size of PLAR and at the location of PLAR, and then proving it that this is PLAR is with the recombinant protein. And then when they do it for membranous, lupus membranous or IgA, they don't find any bands there, and the recombinant PLAR is not being pulled down or not being localized with lupus membranous or IgA. So that's what they're trying to show here. And then the size band from the human glomerular extract is on the right, to show that there aren't any other antibodies, other proteins that are being pulled down. So they're showing you all the way down from 0 all the way up to 250 kilodaltons. And then lastly, they have the unique case, like the case that the AntiNephrin study presented as well. So there is someone with membranous, they have serial samples from them. Proteinuria started going down with immunosuppressive therapy. Serum albumin came up and proteinuria went down, and they have multiple serum samples to show you that the anti-PLAR antibody was present before, but then it disappears. And as it disappears, the proteinuria disappears as well. Again, showing that the presence of antibody is present with disease activity and disappears with remission. And then in their discussion, they talk about that PLAR is present in 70% of these idiopathic membranous. PLAR2 is on podocytes, just like megalin and neutral endopeptidase, which were already known to be proteins associated with membranous before. So megalin in rat models of membranous, and neutral endopeptidase in the pediatric or neonatal membranous. It is IgG4 as is expected for membranous. They're shown that IgG co-localizes with the PLAR2 in the deposits in the biopsy. The IgG eluted from the biopsy binds PLA2R. Serial follow-up shows that antibody level tracks with disease activity. And importantly, it is not associated with secondary membranous, with lupus and cancer, and not with other nephritic and nephrotic conditions as well. So that's kind of their plausibility discussion. Again, so now if we look at the Cox postulate, in one, they show that 70% of those with idiopathic membranous have it. In healthy, it's absent. And then they isolate it by two different mechanisms in this, with the eluting as well as the human glomerular extract pull down. They haven't injected it, so that's pending. Does the cause precede the effect? So again, at that time the paper was initially presented, they didn't have these serial measurements, but since then there have been studies that have shown that serial measurement, showing that the PLAR2 antibody predates and precedes it. Is the association consistent with existing knowledge? They've shown some evidence at that time, and there's been more since then. Similar studies and similar results by other studies that was pending later on has been done. Strength of association between cause and effect, done later. Increased exposure, increased effect, that was again not in this study. Removal of the cause decreases the risk of the effect. They showed some of it in that unique patient of theirs, where the antibody disappears and the disease disappears. And again, the study itself is robust, and we are looking for more lines of evidence. Since 2011, there's been tons and tons of evidence to now be conclusively sure that PLAR2 is the causative, anti-PLAR2 is the causative agent for membranous in at least 60 to 70% of those with idiopathic membranous. So take-home messages that prove causation, we need to show evidence from multiple steps and try to fulfill majority, if not all, of Cox and Bradford-Hill's criteria. May not be possible in one study, but you want to pull multiple studies, multiple evidence, animal studies, all of that to be sure that we are looking at all of it and then saying that this is cause and effect. Association is not causation. Antinephrin may be a cause of some minimal change disease, and we need to look for more data to confirm these findings from multiple sources and multiple evidences. SflT1 paper had showed most of the information, including animal data where they'd injected SflT1 and shown a lot of the Cox postulates that we discussed. And the anti-PLAR2 story we also discussed is causative for idiopathic membranous. So I think I'll take a break here and I'll be happy to answer any questions about this as well.
Thank you, Ajay, for wonderfully illustrating both the Cox postulates and the Bradford-Hill criteria for illustration of causation, and more importantly, clinically important causation, because that is what we're interested in. And these three examples are fantastic examples of all of that. I think the point that you made is that these three studies in their own way have done most of the hard work in illustrating causation. But of course, not one single study is going to be able to prove every single thing beyond all possible doubt. And so subsequently, it's important that these findings are replicated and also strengthened by other investigators and possibly by other types of research, which is consistent with what is shown earlier. So I think all of those points are very, very well made. And these three studies have wonderfully stood the test of time. I think the last one, the nephrin one, is relatively new. But of course, the plausibility is there from the work done by Dr. Helmut Remke and others. So maybe you might want to stop sharing your screen, Ajay, so that we can see everyone. And so any questions for Dr. Kher? Any questions from anyone on the call? So Ajay, if you were to, again, conceptualize doing these kind of studies, studies that try to establish causality, what is the first thing that you will advise people to think about?
Yeah, so I think the studies here span a little bit of the spectrum. So the SflT1 had a lot of animal studies and animal data, while the AntiNephrin and the PLAR2 were predominantly clinical studies. So I think if you do have the capability for animal studies, then you can go from clinical to animal, or bench to bedside, and bedside to bench. And so then you can accumulate a lot of the Cox postulates or the criteria within the same study or within the same group. But if you don't have animal or bench research, then what you do need is to read up or review the previously published animal studies or animal data about the disease or about the cause and effect that you're looking for, to glean those evidences before you start to do the clinical study. So I think it's important to kind of do the homework first to see what are the possible etiologies of causal causes, and then work to design your clinical study and say, okay, now we're going to focus on these factors. Sometimes these days we have tools like genome-wide association studies or full genomics or metabolomics kind of studies, where you can go in blind and say, okay, there is this factor, which is a permeability factor for, let's say, primary FSGS or minimal change disease. And we'll just go blind and we'll look for everything and see which one comes out. So you can have kind of these blind studies. But if you go targeted, you're more likely to be successful if you have biological plausibility and biological suspicion, and you can target to one or two entities. So I think there's those two different strategies. One is you have plausibility, scientific basis, suspicion, and you go after a suspicious agent, or you say, I know there is something here, and I'll go in with a big screening tool. And once I find it, then I will go into the biological plausibility once I know which one to look for. So I think those are the two strategies that I think people can use and have used before to kind of identify specific agents.
Yeah, thanks. So the two, again, just at the risk of repetition, because this is very important. One is to make a very, very well-informed guess based on, of course, science and based on your understanding of disease mechanism, reading of literature, work of previous people to increase your likelihood of success. And second is to use some sort of a screening tool, very high quality screening tool. And that was the approach that was adopted by the SflT1 investigators, Dr. Karumanchi. I know this because I was involved in that part of the work initially. And this is an example of bedside to bench to bedside. So the way it all started is that initially they collected placenta samples of women with preeclampsia, and of course placenta samples of women who had given birth to a normal healthy baby. And they did transcriptomics on these two placenta samples, and they identified which were the transcripts that were differentially expressed. And so they found, of course, a bunch, and they got lucky because the one that showed the highest fold difference was the SflT1 transcript. And it made sense for a lot of reasons. And there comes so this is the use of the screening approach. But then this was combined with existing knowledge, which was the other thing that you said, Ajay, is that they immediately recognized that SflT1 was the receptor of vascular endothelial growth factor, which is required for health of endothelial cells. And we knew that preeclampsia is a disease of endothelial, endothelial cells because of glomerular endotheliosis and endothelial disorder and HELP syndrome type presentation and so on. And so they got lucky. And then they also looked at other literature where it had been shown that anti-VEGF therapy does lead to proteinuria also. So their data was supported by all of these other lines of evidence, and then they went ahead and did the study which you presented. So I think those are the various things, and they got lucky that almost everything that they tried in that particular study, it worked well.
Yeah.
So yeah, that's really important. But very important again that these findings are replicated by others, and most of these, all these three, not three, at least the first two, are used now routinely in clinical practice.
Absolutely.
Questions for Dr. Kher? Any other questions? I think he has really made a very clear illustration of Cox postulates and the Bradford-Hilt criteria. Seems like you have convinced everyone, Ajay, or you have stunned them into silence of some sort.
Maybe a little too much basic science.
I don't think it was too much. It was basic science. It was good illustration of the process and also illustration of how to interpret this data. So that's very good. Thank you. Any other point that you would like to make, Ajay, in the end before we draw this to a close?
No, I think the only last thing is I had thought about talking a little bit about some diet research as a contrast, which I didn't do in this talk because of time constraints, to try and show that what association studies are and how that differentiates from actually proving causation. So there's a lot of diet research that comes and gets headlines on newspapers on a daily basis. And so it's very important to kind of
vitamin D and
vitamin D, diet, or a lot of, so vitamin D still has at least some randomized controlled trials which show that they don't work. but vitamin D levels and disease correlations, those are quite suspect in terms of cause and effect. So I think diet, carbohydrates, fat, sugar, coffee. So take your pick, and there are headlines every day about coffee with X cancer or that, or saves or protects one way or the other. And so those correlations and those papers really need to be looked at for confounders before you try and link them as cause and effect.
Yeah, very, very important. Because all that, if not looked at in a critical manner, can lead to practice of bad medicine.
Absolutely.
All right, looks like we have no question immediately. So again, Ajay, thank you very much for
Thank you,
this
sir.
very clear presentation. And thanks everyone. And we'll be back again next week.
Thank you so much, sir. Thank you, Dr. Kher. And thank you, Dr. Jha. It's always a pleasure to have you, sir.
Thank you.
Right. Bye-bye. Thanks, Puneet.